Okay, this is the second half of what I presented the other day. The other day we talked about toothache, and today we're going to talk about trauma. If anybody wants to look at the guidelines for trauma, the recommended guidelines of the AAE, the American Association of Endodontists, you can get for free online by going to AAE.org. There's a whole bunch of different websites that you can go to for information about trauma. And since this is being videotaped, or we don't call it videotaped anymore, it's being recorded, you'll be able to see all of this. The International Association of Dental Traumatology periodically has meetings, as does the Academy of Sports Dentistry, which is in the United States. And there's a dental trauma guide that's out that Jens Andresen put together. And here is Jens Andresen. The handsome guy is Jens Andresen. He's from Denmark. He is the foremost authority on trauma to the teeth. He has written many textbooks, hundreds of articles. If you want an expert opinion, he is the one to ask. He's the one who's taught me a lot, and we've been good friends. We've written about 5 or 6 papers together. I respect him a lot. This does not come out too well when it's blown up. You could probably recognize this face here as someone who looks a little bit like me. That happens to be my son, who's now 41. Okay, this is when I was a little league coach, and this was my team, and we took a picture of all of them. And you have to realize that by the time they become teenagers, up to 14% of them will have some sort of trauma to their tooth, some sort of injury. Just some statistics. And some of this are international statistics, some are American statistics. But the average five-year-old children, a third suffer traumatic injury to the primary teeth. 1/3. And most often, knocking a tooth over, usually because they're running. They're not very steady on their feet at that age, and they just fall over and hit their teeth. And those of you who are parents probably know that, and you probably have a heart attack every time one of them trips over and they don't put their hands out and they have an injury. 12-year-olds, 20 to 30% suffered some sort of dental injury. Boys more frequently affected than girls. And the most common was an uncomplicated crown fracture. In other words, a chipped tooth. Something that every one of you, when you graduate, you could restore very easily. In order, the most common injuries to children are: 1, falls, that I mentioned before, especially the younger ones. Number 2 is traffic injuries. Number 3 is acts of violence, and number 4 is sports. And that sort of surprised me when I read about this, because I thought sports would be number 1. But at least in the United States, organized sports is really pushing hard for children to be wearing mouth guards. As a matter of fact, next month, we're giving a continuing education course, an all-day course at the University of Texas, specifically on sports dentistry. In the morning, we're going to have several lectures. In the afternoon, after a couple of lectures, including the physician coming in who's a sports medicine specialist to talk about concussion, we're going to be teaching the participants how to make mouth guards, because that's very important. For any of you, when you get out, this is a great way for you to build up a practice. Mouth guards are not that expensive to make. All you need is the machine. And you get one of those machines, learn how to make a mouth guard, make mouth guards for the kids in your high school, middle school, whatever school your kids are going to, and let them all know who you are. And pretty soon their parents will be coming in to see you, their kids will be coming back to see you. It's a great way to build up a practice. Okay, the classification of traumatic injuries that we're going to talk about today. There are a lot of different ways to classify traumatic injuries. We're going to be talking about crown fractures, crown root fractures, root fracture, concussion, subluxation, extrusion, intrusion, avulsion, and a little bit about fracture of the alveolar process. Okay, let's see if this works. I just want you to know how important it is to keep your teeth. Oh, we don't have any sound. Okay. So now you know how important it is to keep your teeth. If your teeth get fractured or knocked out, you want to keep them. Okay. Is there some way that we can get the sound working? We haven't tested this out. Is there somebody here? Because we may have a few of these videos as we go along. Okay. Let's talk a little bit about crown fracture. When you have a simple fracture just of the crown, a little piece may be broken like this. That's similar to this one, okay? This tooth does not have a pulpal exposure. So a simple crown fracture is something that building it up with composite is really all you need. Now, I want you to take a close look at this and take a look here. There's no bleeding. Here there is bleeding. And later on, we'll discuss this a little bit more when we talk about concussion and subluxation. Because even though there's no pulp exposure here, there may be damage that's going to have to be taken care of later. So whenever you see bleeding coming from around here, you're going to have to check up on that tooth periodically. Okay, so here's our buddy who had the injury. He fell down, he had his teeth chipped. You can see he has some scabs up here, so this was a couple of days afterwards. We looked at those teeth. All we have to do is bond it. Is that all we have to do? First thing I want you to do is take a look inside his lip, okay? You have a piece of tooth broken off here and a piece of tooth broken off here. Whoa, look up here. You see that? There are cuts in the lip. Anytime you see a cut in the lip, anytime, even if you don't see a cut in the lip, if you have missing parts of the tooth, check out that lip. Because what we're going to do is take a radiograph. Now, of course, we'll take a digital radiograph. But we want to see if there's anything under that lip. Now, here, and he didn't have anything in his lip. But here's a gal who was in an auto accident, went to the hospital, they took a look at her, they sent her to her boss, who happened to be a general dentist. He restored the teeth, but this swelling never went away. She had this hard lump here, and they were told, just leave it alone. She was told, just leave it alone, but she didn't want to leave it alone. So we took a radiograph of that, and here's what we found in there, okay? So anytime there's a cut in the lip, anytime there's a swelling that won't go away, take an x-ray of the lip. Now, something like this is very easy for you to get out. You don't have to send this person out to anybody special. You know how to get a lip numb. You could do it with some infiltration or a mandibular block or both. Get the patient numb, That'll get their lip numb, make a little incision inside the lip. Don't forget, we're dentists, we work inside the lip. You don't want to go on the outside of the vermilion border because those are hard to heal and a plastic surgeon should handle that. I don't know how it is here, but if we go outside the lip and there's any sort of scar, we're in for a lawsuit. So we stay inside the lip. But all you have to do is make a little incision and find that little piece, take it out, take another x-ray, make sure you have everything out, and maybe put in one suture and you have a happy patient. Because they've been walking around with this little swollen lip and they have this thing in their lip that's not going to go away. It's not going to dissolve. What happens if the fracture is not just of the crown, but it goes further up the tooth? Okay? Here we have diagram of a tooth. The force is coming this way. We have direction of force here, and it tends to break around this area. This is the fulcrum area. This is where it's held in. So you'll see most of these fractures going up in that area. And this is what you might find. Somebody might come in with a tooth looking like this. It may hurt, it may not. It depends on where it fractured. But you're trying to think, why isn't that falling out? What's holding it up there? Realize what that diagram said. That diagram said that there's that fulcrum and it's under the gingiva. So it's the gingiva that's holding it in. And in this case, the reason this patient had pain, this patient actually already had endodontic treatment. You can see the temporary filling in here. The reason the patient had pain was not because of what was inside the tooth, but just because of the gingiva, the gum. Every time you move the tooth, it was like taking that point and stabbing it into the gum. It's like my little ingrown toenail that keeps pounding in there. So you anesthetize the tooth, remove that portion, and you could build it up. If it's through the root canal, do endodontic treatment. If it's not through the root canal, then you don't have to. Okay, what happens if this root fracture is a little bit more at an angle? It comes in, let's see, it comes in more like this, and instead of coming in right over here, it's coming in over here, and it just sort of moves this whole portion. You're going to get a fracture of the root up here. Notice when you get a fracture of the root, it's still around that fulcrum area. So when you have a fracture of the root, it's going to be at an angle, but in the other direction from the crown root fracture. That makes an important point, because if you're trying to discover whether it has a fracture or not, you're going to have to take a radiograph. When you take a radiograph, you may not see anything, but if you angle the x-ray a little bit sharper, more of an angle, more of this type of direction, you could start to see that fracture right over there. Okay? And if you look even a little closer, it looks like it's sort of an oval here. That's because we didn't come in at quite the exact angle. If you come in at exactly the angle, it'll look like it's straight across. Now we have a better way to do it. And you do in the school too, the cone beam. The cone beam will show you that fracture exactly where it is. You just take one cone beam, you could rotate that around, move it around. It's going to be fantastic. You are going to love it. Look at this. This was a gal that came in. She was probably about 8 or 9 years old, would you say? She was walking through the parking lot, and a car was coming by. She wasn't paying attention. The car was only going about 5 miles an hour, but it hit her and knocked her over. She hit the pavement, had some lacerations on her face, a little bit of tar in her face that they had to get out, and her tooth was crooked like this. So she was coming to me from a brand new pediatric dentist who had just opened up maybe a month or two before. And I didn't want to take away a patient from this new person. So I called up the pediatric dentist. I said, I'm sending this patient back to you. She has a fracture. It's very easy for you to take care of. Why don't you handle her? So the patient went back. The pediatric dentist, I thought, had learned all of this stuff in school. Pediatric dentist took one look at this and said, oh, we have to take the tooth out. There's nothing you can do about this. An 8-year-old girl. Don't do that to your patients. You know, maybe she's 8 years old. You could take teeth out and put in implants, but not with an 8-year-old. So what is she going to have? A flipper? Does everybody know what a flipper is? It's one of those, it's almost like a little plastic partial denture that the kid wears, and it comes in and out whenever they want it, whenever they play with it. It's embarrassing to the kids. This happens to be something that's very easy to treat. And I'm not trying to turn down patients. I'm not trying to get patients not to go to endodontists, but all you have to do is take your fingers and push that together. In this case, since it happened like a day later that she was in, I anesthetized her because there's a blood clot forming up here, and she wasted so much time going back and forth to me and the other dentist that I'm sure there's a blood clot that formed up there. If there's a blood clot forming and you push that up, there's going to be a lot of pain from the pressure. So you anesthetize the patient. I pushed it up as far as I could. We splinted it, and I'll show you a little bit about splinting later. And look at this. This is 1 year post-op. The apex is forming. You could sort of see the outline of where the fracture was. No endodontic treatment. If there's a fracture, remember what I said yesterday? You need bacteria to have a pulpal lesion, to have any sort of abscess. No bacteria got up in there. It was all contained within the periodontal ligament. Here she is 2 years later. Okay? Here's the tooth. That's the upper left central. And then look at this, 7 years later, she's having braces, and here we are. This is the tooth that was fractured. 7 years. Now look at the other tooth, the one next to it. See what happened to that? It calcified over the years. That one had no injury that we could see, okay? But that was what we call a concussion. There was no bleeding around it, but there was a concussion. And I said to you, with some of these teeth, you have to keep an eye on them. If a tooth is calcifying like that, what do you do? Anybody want to guess? I know, I'm turning away patients. You do absolutely nothing. Okay? So this is where we were going yesterday. We were talking about diagnosis is important. Diagnosis is very important here because you not only have to know when to treat, but you have to know when not. This is where we were going yesterday. We were talking about diagnosis is important. Diagnosis is very important here because you not only have to know when to treat, but you have to know when not to treat. And there were some studies done in North Carolina, Holcomb and Gregory. They did some studies about calcifying teeth and found out that the success rate of doing nothing was better than the success rate of doing something. If you went in there and tried to do endodontic treatment, and their study honestly was done before the microscope, so I'm sure there are a lot of mishaps. But even now, the success rate of doing nothing with the calcium, you may have a problem. If you do have a problem, if it becomes necrotic, if the patient has symptoms, you could always go in and with the microscope, I bet you could find that canal. Okay? So, do nothing. Look at this. This one had no treatment. Dennis didn't even look at it. This is a guy who was in a car accident. As he was going to the hospital, he noticed his tooth was sort of a little longer. He just pushed it right back up himself and forgot all about it. He never went to the dentist. 2.5 years later, he came into the school. We were talking to him about it, and he said, oh yeah, I had that car accident, I just pushed it up. Well, he didn't push it up straight, you see, but look at that. He still has that tooth. That's better than taking the tooth out and him having an implant in there. And this one had no discoloration. He probably has a blood supply coming in from where that fracture is, and a nice vital tooth here. No necrosis. So sometimes these patients could treat their own. Now, what we find sometimes is sometimes we might have a fracture of a root. Here's one, if you take a look at number 8, which is this tooth here. There's a fracture, there's a pulp exposure. So we decided we're going to do endodontic treatment. Okay? Here's the endodontic treatment. That's fairly acceptable for decades ago. This patient came back 3 years later and had braces on, and the braces moved the tooth, and now look what's happening here. Now, if you look back here, we really don't have a good angle, but if I look carefully, maybe I see a little thickened ligament here, maybe I could see a little line here, but it's easy to read that x-ray after it's already done, after you see what happened 3 years from now. Okay, so we have this. What do you do about that? Come on, you should know by now. Nothing. There's no bacteria up there. It moved around, so there's no bone up in here. There's just some granulation tissue. And then we check that again. Look at this, 13 years later. Still comfortable, the braces are off. We may be getting some bone fill in here. 13 years and did nothing. Now, I have friends of mine that told me we should have gone in and removed this segment years ago. Why? Okay? Sometimes the best treatment is no treatment. You have to diagnose it properly, know what's going on up there, figure out whether there's bacteria up there or not. If there's no bacteria, there's no infection. If there's no infection, you could leave it up there. As a matter of fact, we're better off leaving it up there because this is keeping bone support up here, and especially if this fills in a little bit. And that tooth is solid. Do nothing. Okay. This was that first picture I showed you. This is concussion and subluxation. What happens with concussion is you just get some squeezing of the periodontal ligament. And that's about it. Sometimes because of that, it's a little bit traumatized, and the patient may complain that the tooth feels a little high. And most of the time when that happens, you could just gently relieve the occlusion, grind it down a little bit, and again, no treatment. Sometimes you'll see bleeding like this because the periodontal ligament has been torn. Okay? Now, this might be a different story But the best thing here is to clean this off and check the occlusion if there's any interference with the occlusion. But many times, there's not enough torn for bacteria to get all the way up here, because the little bit of blood that came out is sort of washing everything away, and you don't have a big infection up there. And most of these will require no treatment. Okay? So here we've gone through most of the lecture, and I'm telling you not to do anything. So you're out of a job. Okay. These teeth you should monitor, though. Monitor carefully, because you don't know if any bacteria did get up there. And maybe they did. And something we find with concussion is sometimes the tooth actually got torqued in the socket a little bit, and maybe the blood supply at the apex was cut off. Normally it's not. Normally you have a good supply up there, but maybe it was cut off. And maybe something will happen later on. So this is what we do if something happens later on. Okay? Here's somebody who had trauma. You can see it's an open apex. Patients complaining about pain to hot and cold. So what does that mean? It means is it vital or non-vital? It's vital. The pulp is vital. Okay, so we want to get the rest of this apex to grow. We want it to close like a normal apex. And even if it's straight up and down, the last part to usually close is the labial and the lingual. So if you see what looks like a straight canal, you say, oh, I could put gutta percha in here. Nah, because it's open coming out sideways. Now, if you have a cone beam, you could see that. So keep using the cone beam. So what we're going to do is apexogenesis. Apexogenesis is a way to try to keep the pulp alive long enough that the pulp is going to close the apex of the tooth. And we're going to put something in here. We're going to do a pulpotomy. That's all we're going to do. Now, years ago we tried using calcium hydroxide for a pulpotomy. Remember I told you that people used to use calcium hydroxide a lot for pulpotomies, and that you really shouldn't do it? This is the reason why. Because calcium hydroxide encourages the formation of a bridge. Sometimes that bridge could be over here, which is sort of treatable. Sometimes it could be up here. And then you're going to have to go back in, because also what happens with calcium hydroxide is that it's so alkaline, it's pH of about 12, it's actually going to cause some necrosis of the pulp. And because you were into that pulp, because it was infected, it'll keep progressing and form an abscess. So you want to get this root canal treatment. This is one time you don't say don't do anything. You want to go back in here. So what we're going to have to do is drill through this. And you could see when I did this, I even started to go out through the side. It's very tough to go up there and have your burr in exactly the right spot. So you have to do it carefully. You have to take a couple of radiographs to make sure you're in the right place. If you don't form that bridge at all, you're in luck. You don't have to worry about that. So how about doing a pulpotomy with no medicament? Just put a piece of cotton in there and a good seal over that. And in most instances, it'll form fine. It'll stay vital long enough for the apex to form. You don't have to have it vital for years and years, because the apex is going to form fairly quickly. You don't want to put MTA in there, because then you're going to have to drill through concrete. And drilling through a bridge like this will be easy compared to drilling through concrete. That's what I just said about the MTA. Some people think eugenol is the best to put in there, but we're getting away from that. We discussed that this morning, that eugenol, especially free eugenol, causes inflammation. Eugenol could travel along the nerve pathways and form inflammation within the nerves further away from the tooth. Eugenol, free eugenol, is carcinogenic, supposedly, according to some of the studies. Why not use it? So we're getting away from the eugenol. What do you do if the tooth has a non-vital pulp? Here we have a tooth that had a little chip. It was repaired. In those days we had composite that wasn't necessarily radio opaque like it is now, but you could sort of see the outline. It was repaired, but this became necrotic. And there was a sinus tract here. This is tracing the sinus tract. And there's a cute little mesiodens here too. But that's besides the point. Okay, what we did years ago is we did calcium hydroxide. It took sometimes years to get the apex to form. Sometimes we could do it in months. Then we went to MTA, and I'll show you that, and that we could do in one visit. Okay, so here's how we did it. Whether it's calcium hydroxide or MTA, you could take some old amalgam pluggers that you used to have and put the calcium hydroxide or the MTA up there, plug it with a plugger, and make sure you have it where you want it. Okay, so here you see it partway up the tooth. That's not where it should be, because if you leave it here, you might form a bridge here. Imagine going through a bridge here. So you want to get the calcium hydroxide all the way up, or the MTA all the way up. So you do it until it looks right on the radiograph. Then with the calcium hydroxide, we took the radiograph in 3 months. We looked to see that there's a bridge forming here. And there's the apex forming. Okay, then we have to test it. So you want to take a file and move it around, put a little bend at the end to make sure that it's forming, especially on the labial and the lingual, because those are the last places to form. So we test it with that. We rotate the test file to see if there are any big areas we can get in. And if there are none, go ahead and obturate the tooth with a nice warm gutta percha technique. And sometimes we could even get some gutta percha flying into little tubules that might be up there. Then we stopped using the calcium hydroxide because we had MTA. Here's a patient that came in about 2 years ago to our clinic, and this was done by one of our residents. And some of the perio residents took a look at this and said, take it out, put an implant in. But the tooth was firm. Luckily, the patient didn't want to take it out. The patient wanted to save that tooth. So Parastu Rouhani, and I'm giving her credit, I didn't put her name here, so I apologize. She's the one who did this. She cleaned this out, put MTA in here, nicely packed it right up to this level here in one visit. And then 15 months later, look at this. This healed very nicely. The tooth is nice and firm. That patient's going to keep that tooth for many, many years. So if you're going to do a pexification, I would really recommend considering MTA. Now, this is what's happening nowadays. Those of you who are reading the Journal of Endodontics are reading a lot about regeneration. Regeneration is the new way to go. You know, yesterday I told you about this fellow, Collins Akwin, who's from Nigeria and is starting the first department of endodontics in Central Africa. And he decided to call it the Department of Endodontics and Regenerative Dentistry because he's been so turned on by regeneration and what we're doing as far as our research there. So with regeneration, it's still in its infancy. If you look here, Alan Nevins, back in 1977, did some of the original research on regeneration, except he didn't call it that. He really was just trying to create a pulp in there. And what he did is he formulated a gel. If you look in this picture, this is part of the gel he formulated. It was a collagen gel with calcium and phosphate in it. And he would inject that into the tooth. And here's an x-ray that he had sent me because I was doing some of this work with him. He was doing it at the same place that I was doing my residency. And this is what the histology looks like. He did calcium hydroxide on one side, the regeneration on the other side, and look at the apex that he was able to form, okay? If you look at, you probably had enough histology this morning, but here you can sort of see the lighter pink outline of where the open apex originally was, and this is what was built up with this calcium phosphate gel. And if you look carefully inside, there's sort of a dystrophic bone or dentin forming. He really didn't know what to call it. There's tissue forming in here that looked a little bit like pulp tissue. But again, he didn't get proper funding and never continued with that. But now there are a lot of people that are continuing this with this work. We still don't have a very definite protocol of what to use, and maybe in the endodontics program you'll be learning a little bit more about it. Basically what we're doing is we're irrigating with a triple antibiotic paste. Some people with a double antibiotic paste because they're taking the tetracycline out because it's staining the teeth. So we're irrigating with antibiotics. We're working at our school with different scaffolds to put in there. There's one type of scaffold that you could put in and then it'll cure, and it'll cure to the shape of the canal. And we could put different types of inflammatory markers in there and growth factors in there to allow bone or pulp or cementum or dentin or whatever you want to call it to start forming in there. So what we're trying to do is, in essence, grow a new part of the tooth. And then there's somebody taking it one step further at Nova University where they're actually forming whole teeth. And if you extract the tooth, you could put this whole new tooth in. So there's a lot going on. The future is very bright. There's a lot that we're going to be doing in the future. Okay, now, closed apex teeth. If there was a concussion or maybe a subluxation and some bacteria did get up there, then maybe you're going to find something like this. Patient came in. I don't know if you could see from all the way back. There's a little dark area up here. It was pain on palpation. An abscess is forming. That means bacteria got into the tooth. I don't see a canal. I see a discolored tooth. The discolored tooth means blood vessels were broken in there. We have blood extravasating into the dentin. You have hemoglobin breaking down and corroding And we're going to want to get in there to bleach that, besides take care of that abscess up there. So, go in, find the canal with the microscope, do the root canal treatment. This student got a little pigtail up there, but it's still healing okay. And at the same time, bleach the tooth. Look at that. From one time to the other. This is the new tooth, and then this has to be restored with composite. We don't have to take out the tooth. We don't have to put in an implant. I'm not anti-implant, by the way, but I just believe in saving our own teeth. You know, endodontists are still the ones that still continue to save teeth. Implants are great when you can't save a tooth. But when you can save a tooth, the patient is very grateful, especially if it's an anterior tooth. We could always take it out later. We're going to continue down the line with extrusive luxation. Here's a tooth that's sort of pushed out of the socket a little bit. And what happens here is you have a breakdown up here, a pooling of the blood, and when it was brought down, there's a disruption in the periodontal ligament all the way up there. Not always, but sometimes bacteria are able to get in, and you're going to end up with needing endodontic treatment. But the first thing you have to do is get that tooth back in because it's been pushed out. So here's I think she was about 15 at the time. She was riding her bicycle. She had a sweater on. It was getting too warm. She took the sweater off, put it in her little basket, and the arm of the sweater went down into the spokes and stopped the bike, and she went right over the top. Happened to be one of my daughter's best friends. But she didn't want to bother me over the weekend. So she went to her dentist, and of course her dentist said, well, let's find out about it on Monday. Nothing we could do about it now. She was being bothered because this was lower than the other teeth. So, you know, she called my daughter. My daughter explained the story to me. I went into the office. We saw her, anesthetized her because it was a couple of days later, and pushed this tooth up into the socket so that it's now level. And you can see in pushing it up, there's some bleeding coming through because we had to break through that blood clot that's there. So had to anesthetize it because it didn't just happen. Any of these things, if it just happened on your doorstep especially, you could push that up. If somebody calls you in your office, just tell them to push it up there. Like that guy that did it from the car accident. So anyway, did that, but look at this. She ended up needing root canal on both of those teeth. But this is 6 years post-op. That was at her wedding. Well, not at her wedding. She came back to town for her wedding. But she wanted me to check her teeth to make sure they'd be okay when she smiled for the camera. So it was a toss-up whether she was going to need the endodontic treatment or not. These are the things that most of you could easily do in your office. It could be a good practice builder. Now, what about lateral luxation? This is something that you're going to have to remember this diagram if you have a patient that comes in like this. It's called lateral luxation, but actually the tooth gets intruded over here and pops out of the bone here, and you end up with a fracture of the labial portion of the bone, and you could actually put your finger up here and feel that tooth coming out. Now, the problem with this is too many people try to push this up like all the others. But, you know, when you see this, you have to realize, if you push it up, what's going to happen? You're pushing it out here. It's not going to go. And some people will push and push, and then they'll say, well, I have to straighten it out. So they'll try pushing this part of it out, and all you're going to do is fracture the tooth because it's being held up here. So what we have to do with something like this is actually pull it down, either with your fingers if it's loose enough or with the forceps. Actually take the tooth out more than it is. Extrude it. And then with your finger you could push the top part in and the bottom part out. Okay, once this is down here, so that it looks like this, and then you could push it up into place. Okay? So remember this diagram, because there's a good chance that somebody will come into your office with a tooth like that. It's pushed in, you pull it down, back into place, and up. And this is what it's going to look like. Here's when we pulled it down, pulled that out, and pushed it up. Take a radiograph to make sure it's in the socket. And this is, up here is where the damage was, where it was sticking out of the tooth. So some of these things are very easy to do if you just remember how to do it. How about intrusion? Intrusion happens to be the most damaging trauma event of all to the teeth. Maybe with the exception of having a tooth knocked out completely and losing it. With intrusion, 100% of the time you will need endodontic treatment. No doubt about it. We don't really know why, because it doesn't seem like bacteria will get in when it's pushed in. But apparently there's such a crushing injury of the periodontal ligament and the bone around there that bacteria is going to get in there somehow. And nobody has shown exactly why yet. So here's from some of Andreessen's studies. This is in closed apices, and you can see here if there's no luxation or concussion or even a subluxation, very few of the pulps will actually become necrotic. If tooth is extruded, you'll have a little bit of pulp survival, lateral luxation, a little bit less. Intrusion, complete pulp necrosis, no pulp survival. Same thing with deciduous teeth.